Good morning. My name is Kieren Marr, and thank you for joining us for this discussion of COVID-19 associated mucormycosis. Here's the requisite disclosures. I've been on advisory boards, received grants, and have equity and ownership in a diagnostic company. So this is an outline of the talk today. I'll be really presenting some background on the collaboration between respiratory viruses and fungal infections with a focus on influenza-associated aspergillosis and COVID-associated aspergillosis. And then I'll talk about COVID-associated mucormycosis. A little bit of a review to remind people, we inhale these organisms all the time. They're robust environmental organisms, and you really cannot avoid them. The spore type does dictate in some part the location of where the organism can appear. Very small ones, such as those that are given off by Aspergillus species, can end up deep into the lungs, and larger ones, such as those that are associated with mucormycosis, can get lodged in the upper airways and the sinuses more often. As I'll show you later, some molds can grow better in certain environments than others. And so there's both geographic and seasonal variability. I think the best collaboration between respiratory viruses and molds has been documented with severe influenza virus infection. And this has been driven by groups in Europe, largely in Belgium and the Netherlands, that have done very large studies of people admitted to ICUs with severe influenza that have shown very high rates of secondary infection, up to 19 to 30%, with very high mortality. This can be variable across the world, and the actual rates may be higher because of current disease definitions and because the diagnosis is difficult to achieve, but everyone needs to be aware of this as a secondary complication of influenza, and early recognition is critical. Because of that, when COVID-19 came into appearance early during the pandemic, these European groups were largely aware of that as a potential secondary complication and started reporting multiple different case series that really did document very sizable incidents of disease in people that had severe COVID-19. And I think that this is really appreciated in most places globally now. The one thing to understand pathobiologically is that aspergillosis occurring with severe viral associated pulmonary disease, it may not be the classic invasive aspergillosis that we appreciate in severely immunosuppressed patients, like people with leukemia or allogeneic bone marrow transplant patients, which would be classic invasive aspergillosis. Because I want to point out that the virus can destroy clearance, normal clearance of the organism, such that spores then generate hyphae that are very inflammatory in the airway. This can then further destroy the innate defenses and epithelial barriers in the lungs and allow for invasive infections. But what it also does is it turns into a mix, potentially, of Aspergillus overgrowth, causing an inflammatory condition in the airways, such as tracheobronchitis, and a mix of potential necrotic or invasive aspergillosis from the airways. And so it's not simply the nodule with potential angioinvasion that we appreciate in other hosts, and can be a mix of more airway and invasive infection. So today we want to really focus then on what has become apparent worldwide, and more so in certain parts of the world, especially India right now, and that is COVID-associated mucormycosis. Mucorales is the order of these organisms existing in the phylum Mucormycota. These are thermotolerant and, again, ubiquitous organisms in our environments. They can be both outdoors and indoors, and do have a predilection for growth in certain types of environments. There are 55 genera, 261 species, and about 38 organisms that have been noted to cause disease in people. The most common of those organisms are listed here. I think everyone appreciates the clinical syndromes of mucormycosis. These are most commonly associated with sinoorbital disease with or without invasion into the brain. They can present with a number of different clinical syndromes: fever, headache, congestion, proptosis, evidence of eye findings, or evidence of invasion into the brain at presentation, and are most common in diabetics, in people with iron overload, and people who are immunosuppressed. Pulmonary disease also occurs. These lesions can be rather necrotic in nature, such as what is shown here, but very difficult to distinguish from other filamentous organisms that cause similar presentations in disease, such as aspergillosis. Again, these occur most commonly in people who are immunosuppressed, such as people with leukemia, bone marrow transplant, organ transplants, etc. There are less common diseases that are now very well appreciated and we all need to be aware of, and that is necrotic cutaneous disease that can occur, for instance, with trauma, burns, or after exposures. There's GI disease as well that is, I think, probably very well underdiagnosed. This occurs most commonly in people who are malnourished, neonates, and some immunosuppressed as well. The type of disease is largely dependent on the host as well as the microbiology, and can occur with some of these conditions shown here. Looking at the global epidemiology pre-pandemic, you can really understand that there's wide variability of reported mucormycosis across the world. I would say, first off, understand that the prevalence is largely underestimated because these are difficult diagnoses to make. But if you look at this table in depth here, you'll understand that India actually had the highest prevalence compared to all of the countries across the world, leading up to about 0.14 per thousand population, which is actually 80-fold higher than that in developed countries. Most of these cases are associated with the underlying diagnosis of diabetes, but is very variable. In India, most case series had reported that the bulk of people did have diabetes as a risk factor, and that is largely associated with the nationwide prevalence of diabetes that is very high, and in some regions, people with not very controlled disease. Also point to the fact that in some of these case series, seasonality has been suggested, which can explain why this could occur in certain times of the year, more so than others. If you look very closely at the epidemiology pre-pandemic, you can also understand that there's a difference in microbiology depending on the region of the world that you're in. Rhizopus by far is the most common cause of sinus, brain, and pulmonary disease all across the world. But there are regions such as these studies from Europe that, for instance, emphasize a different organism like thyma that is a prominent cause of rhinocerebral and pulmonary disease. This is a good example of this case series from France. In India, and especially in southern regions, apophysomyces, which causes more GI disease, can be reasonably common. And so you can understand that these organisms grow in different parts of the world, and that can really dictate both the type of disease that presents as well as how often. Moving towards COVID-associated mucormycosis, or what some people now call CAM. Unfortunately, as of May, there were greater than 28,000 cases that were documented and reported in India. We don't have good detailed data on all of those cases as this country has struggled to deal with this epidemic within the pandemic. This is a systematic review of the literature that I'm citing here that summarized 99 cases from 30 studies, and 72% of the cases were reported from India. Most of them occurred in men, 7-to-1 ratio, with a large predilection in people with underlying diabetes. It was noted that this was diagnosed in the context of severe COVID-19 in 63% at a median time of 15 days, but 37% of those cases came to presentation and diagnosis after resolution of their severe COVID-19, and 24% occurred only with mild COVID-19. So there's a reasonable spread of who would be at risk for COVID-associated mucormycosis. Steroids have been given in 85%. For the most part, the bulk of people had rhino-orbital or rhino-orbital cerebral disease, minority pulmonary disease, with a rather large mortality rate at 34%. Another study was a larger study performed by ophthalmologists who were taking care of people in India during this second wave of COVID. And they summarized the cases that they had seen with a large countrywide reporting mechanism. The 2,826 patients were managed by in this report. They reported that the highest rates were in the states that were also associated with the highest total COVID-19 cases. Not surprisingly, all of these overlapped and most of the reports came from there. One of the things that I want to show is this temporal sequence that I mentioned in the prior slide, which is that most cases did occur within that first 10 to 15 days, but you can see the spread of days subsequent to COVID diagnosis and the variability of when people presented. So this clinicians have to keep aware of that as a potential complication of COVID and potentially its therapies. There has not been a lot of GI mucormycosis documented in the context of COVID-19, and potentially that's a signal of the pathobiology of the two different manifestations. Here I'm just summarizing the pre-pandemic data on GI tract mucormycosis, and it occurs in both immunosuppressed and non-immunosuppressed hosts, presents largely as ulcers, masses, hepatic lesions, as well as necrotic lesions and vascular complications. Largely, the reports have been in India as well as some in the US. You can see these are rather small numbers here, though. It is probably underdiagnosed. Outbreaks are associated with food, medications, and in some settings, oral appliances such as tongue depressors. I'll just note that there's one post-COVID mesenteric necrosis case that was reported. Whether this is underdiagnosed in this context is unclear to me, but something that everyone should be aware of. Of course, COVID-associated mucormycosis has also been reported outside of India, although with a smaller prevalence. If you look at the bulk of the data presented to date, the prevalence appears to be less than 1% in other countries. And in other countries, there's more host variability, with some series really emphasizing risks associated with immunosuppressed states, such as solid organ transplant. There's also, if you look very closely, potentially more microbial variability. Not surprisingly, I'll just point to this one small series from the Netherlands that noted that one of the cases was lichthymia at a 1 of 4. And so that really largely represents the kind of epidemiology that one would expect in those regions. So let's talk a little bit about the risks and pathobiology. And I like this slide, or this figure that was presented in this review by Chakrabarty just recently. It emphasizes that the risks are largely associated with environmental factors that lead to exposure, and these can be indoors, associated with agricultural activities, or with regular exposure in other outdoor environments. And this is the setting in which people get exposed to a large amount of the organism in their airways, and the host factors. And that can include steroid use, diabetes, or iron overloads. Those are the complications that are most commonly associated with rhinocerebral mucormycosis in the context of COVID-19. And there's some pathobiology associated with that that's quite interesting and is just coming out. Classically, we've associated risks of mucormycosis with steroid use and hyperglycemia, and thought that this was largely secondary to diminution of effector function from neutrophils and macrophages. More recently, there's more emerging from animal models and small case studies on what the virus can be doing to increase risks beyond the classic paradigm of impacting neutrophils and macrophages. And what has been suggested is that the virus, because of the damage in the airways, can impart delayed mucociliary clearance, much like aspergillosis, where you get more buildup in the airways. Ketosis can be exacerbated by virus-induced islet cell dysfunction in the pancreas. And this is another of those secondary complications from this virus itself that may be leading to a particular predilection to mucormycosis in certain regions with a lot of people with diabetes. There may as well be dysregulation of iron homeostasis and overload, and we all appreciate that in the setting of COVID-19. One of the very important variables that has been observed is that endothelitis from the virus itself can increase expression of the GRP78 receptor, which is the glucose-regulated protein receptor, a heat shock protein that has the function of both impacting both virus and spore internalization into the endothelium. So there may be actually a receptor that is upregulated in COVID or SARS infection here that promotes adhesion of these organisms to the endothelium and then exacerbates its ability to cause disease. I'll turn to management now, and the best summary that I've seen is again from Chakrabarty in 2021, has just recently been summarized. This is a proposed management algorithm that has been detailed by consensus. And it separates the things that we need to think about into diabetes control, reducing the steroids, discontinuing immunomodulators that we can discontinue, considering surgical debridement, and especially when it involves the eye as well as the lung, as well as medical therapy, giving adequate hydration, etc. And then the type of antifungals that we should be considering, going from optimal to potentially suboptimal. And let's kind of go through that. The liposomal or lipid amphotericin formulations at higher doses, 5 mg per kg per day or greater, are recommended. When that's not available, amphotericin B-deoxycholate at the higher dose that is very poorly tolerated. When that's not tolerated or not available, the mucormycosis active azoles, isavuconazole or posaconazole. And when that's not available, itraconazole, as the historic data have demonstrated that there's at least some in vitro activity of itraconazole against these organisms, although we have much less robust clinical outcomes that have been documented. I would refer you to this review and to the consensus panel that generated this summary to really consider how to approach these patients, especially if you were in one of the regions that has some limitations on availability of antifungals currently. So with that, I'll conclude by saying that these filamentous fungal infections are increasingly recognized with severe viral infections, and there's a complex pathogenesis, maybe something associated with COVID-19 that particularly increases risks for aspergillosis or mucormycosis. And this is certainly impacted by our treatments that are immunosuppressive, but beyond that. Largely, some of the epidemiology has been driven by hosts as well as exposure, and it's certainly a setting where we need to be aggressive with regards to diagnoses and management. Thank you for your attention.